Hello, everybody. Hello. Hello, and welcome back to the SimKit podcast. Today, we're going to be talking about atraumatic knee pain in the emergency department. Something that if you're practicing in the ER, you're going to see. You've seen it time and time again. But there's a couple of nuances. There's a couple of specific questions that I wanted to get some expert consultation, some advice. And we are joined today by someone I'd say is overqualified to be a guest here with us in Dr. Robert Parisien, who also happens to be a good friend of mine, a med school buddy. And so it's great to have a familiar face, an old friend on the podcast. But for those who don't know you, Dr. Parisien, tell the listeners a little bit about yourself.
Well, I first want to just comment, as you were saying, so Dr. Hine and I go way back to medical school, which is quite a ways now. It's a few gray hairs on both sides. We weren't quite there back then. I always like, even though I'm a bit older, I always like to say that he's catching up on me.
I am. I think I'm definitely older now than when we met. You were, and I thought you were old back then. So what does that say?
I was old back then.
Yeah.
So I'm even older now. But no, it's wonderful to be here. Dr. Hine, I really appreciate it. And I can say to everyone who has hopefully been following this podcast and that continues to follow this in the future, what you're doing truly is revolutionary here, and it's so valuable for trainees, and it's also valuable for attendings who aren't utilizing, all of these procedures on a day-to-day basis, which is some of what we do in medicine. And I think to also have subspecialists on like myself and others to talk about certain topics is helpful because, we need to continue learning in this medical environment and community, and how better to do that in today's day and age is via a podcast and getting, an interdisciplinary conversation going. Also, I do want to say to everyone that this gentleman here, having known him for as long as I have, and all the people that I've encountered in medicine, I can say is one of the kindest, one of the most caring, and one of the most compassionate people that I've ever met. And I'm not just saying that because I'm here on his podcast. That is the truth. And so I'm looking forward to our discussion tonight.
Well, thank you, Dr. Parisien, and probably blushing. Hopefully it's not coming across on camera too much. Thank you for the kind words. And thank you for talking about me. Tell me a little bit about you. Tell us about your background and why you're the right person to talk to about this topic.
Well, a little bit about myself. So I'm from Maine, small town in Maine called Biddeford. I was an athlete growing up, and I had some injuries back in the day, and some surgeries, and some great orthopedic surgeons that took good care of me and got me back to playing. And so that was really the impetus when I was about 14 years old to want to pursue a career specifically in orthopedic sports medicine. And so I did that, and through the pathway, I met Dr. Hine at Tufts for medical school, and I went on to Boston University, did my orthopedic surgery residency at Boston University, did my first fellowship, sports medicine and complex shoulder surgery at Boston University, then went on and did a second fellowship focusing in sports medicine, but really cartilage restoration, cartilage repair, which is the big workhouse really is the knee. We're doing some in the hip as well. But really the knee. So I did a lot of that at Penn, and I was a team doc for Penn Athletics at that time. And then I did my third fellowship at Harvard in hip preservation. So 1-year fellowship in hip preservation that really ended up being at Boston Children's Hospital and New England Baptist. And then now I'm in sports medicine practice at Mount Sinai Health System in New York City. My practice is really shoulder, hip, and knee sports practice.
Fantastic. So no more fellowships. 3, you think 3 was enough? Are you sure about that?
2 traveling fellowships after that. We could talk about those if you like.
No, I think we're with the message is received. You are an expert among experts in the area. And thank you so much for being a qualified person to bring on the podcast for our listeners. And, again, just great to have you on board and have such a familiar, handsome face on the other side of this podcast. So Bobby, Dr. Parisien, Robert, thank you for joining us. All right, but we're not here to compliment each other. Talk about the old times. We're here to talk about atraumatic knee pain. Now, this is so common, as I said, in the emergency department. So what I want to really talk about a bit is 1, our history, 2, exams, because I have an exam we'll go over here, and I think it's probably akin to what many of us, the jacks of all trade emergency medicine docs are doing. and then talk a little bit about our workup and our follow-up plan. So it's to, obviously we want to hit the, things we don't want to miss, right? The don't miss diagnoses. That's our job as ER doctors. And we're going to talk about septic arthritis and the likes, but to be a good provider, to be a comprehensive care physician, we want to do more. We want the care to be accurate. We want to avoid things that are wasteful if we are doing any of that, and add value to our consultants who are going to be referring, or we're going to be referring to, so that they are ready to take optimal care, not have to repeat tests or do tests that we simply negated because we didn't know we should do it. How's that sound, Bobby?
That sounds great. I would say that no matter where you are, especially though if you're in a community setting, get to know your subspecialists that you may be referring to. And if you are in a community, let's say in Maine, where I'm from, right now, where I practice now, where I'm from, you can certainly get to know who your orthopedic surgeons are, your neurologists, your neurosurgeons, your cardiologists, and get a sense of what they may want as far as some sort of a workup, or do they want the patient seeing the PA, or when do they think that patient should be bumped up? So really communications and getting to know that team and that environment that's serving your community. I would say I still do that in New York City even. So I know my colleagues who are my physiatrists, and we discuss constantly. I actually train their residents to teach them things in ways in which I would like a patient to be worked up and what sort of imaging I think they should have. And so just, I guess, generally speaking, before we get into some details here, have those conversations, get to know the people in your community and understand how they would like to see a patient worked up, and have those conversations regularly.
I like that. I like that little pearl right off the bat about how we communicate, how we interact in the hospital, outside the hospital, having those relationships, knowing what they look like, knowing their voice when we see them in the ER, asking, hey, how's that person doing that I sent over to you? And being able to get that feedback, right? Because there's obviously going to be nuance and variation of care. We're going to give you strong, well-founded, education-based recommendations here, but you might find your orthopedic say, hey, stop ordering that test on that synovial fluid, or please get this, if possible, for their follow-up with us. And so having that collegiality is just going to be huge in terms of the quality of care that you offer and making sure that everybody's on the same page.
And things change. There's reasons why there are subspecialists, and you can't. I mean, it's even difficult for us to keep up with all the literature that's coming out. But it's really challenging for an ED specialist to keep up with all of the literature across all of the subspecialties. So things might change and things might adapt in time as they do. And so it's good to be aware of that. And that's also could be helped by having those conversations and those relationships with your subspecialists.
Good point. Good point. Thank you. All right. So I want to frame our conversation today around like a typical case, stuff that we see time and time again in the emergency department. So let's paint a picture. John here today. John, he's a 58-year-old painter, right? So he's up and down, he's on his knees, he's working the trim, he's doing those things, comes into our ER with 3 days of right knee pain. This isn't totally new to him. He says, yeah, my right knee's my bad, right? I got the good knee on the left, my right knee's the bad knee. It acts up on me from time to time, but it's really never been to this degree, and it's never really lasted more than a day or two. Today's day 3, it's more than typical, and it's more intense, lasting longer. Took a little bit of Motrin. He's usually back at it after that. He's tried that, obviously, and it hasn't really done a lot, leading to him coming to the ER. Background history for him, he's got some mild hypertension. He takes lisinopril regularly. That's doing pretty well there. He's a classic American. He's got a little bit of obesity with a BMI of 42. He's working with his primary care doctor to drop some of those LBs. But otherwise, he's a pretty healthy guy. He'll admit, kind of putting his head to the ground. Yeah, I do smoke a pack per day. I'm working on that too. But otherwise, that's his story. So off the bat, Dr. Parisien, anything else we need to know about John the painter?
Well, in these scenarios, first of all, when you're atraumatic, you really want to drill down, because many times these aren't necessarily atraumatic. In a sense, they haven't had a car accident. They haven't had an injury that they can point to and say, yes, yesterday I twisted and I felt this and this popped or something like that.
Sure.
However, they might say, well, you know what? I've been working a lot lately, and I've been up and down this ladder for the past 3 days, way more than I ever have, or I've been on my knees, a lot more, on this current job that I've been on, or I've been playing pickleball recently that I picked up, and I've been playing. I played 6 hours yesterday. I played 12 hours the day before that, and before that, I didn't play any pickleball. So, these are all a level of trauma that in this patient that you're describing, this sort of middle-aged patient. So I'd want to know what their activity level is, at least, or anything change in their activity level recently. Now, from an orthopedic standpoint, when we're talking about joints, we're talking about musculoskeletal problems, it's always, where is the pain? How is it reproduced? When do you notice it? Is the joint swelling? Is it not swelling? Things like that.
Sure. Yeah. So like our PQRST kind of elements of the pain. And I like that sort of either repetitive injury or micro trauma based stuff that we really should be pinning down the patient on a little bit more. So awesome. All right. So we got some of that information from him. He did say up and down on my knees, back and forth, maybe non-specific about where it hurts. He touches the front of the knee as the area it kind of hurts all over. But let's get into his exam, right? Meat of the matter there a little bit. So when assessing atraumatic knee pain, I have it pretty, I don't know if it's rudimentary. I'll lean on you, Dr. Parisien, for this, but it's a pretty straightforward exam. Neurovascularly, I'm going to be looking for that DP and PT pulse. I'm going to check their sensation on the medial and lateral aspect of the foot in the sandals gap, make sure they can dorsal and plantar flexion of the ankle and the great toe. That, I can do that in 15 seconds or less, really, with the patient. Then onto the knee specifically, obviously, I'm going to feel a bit above, feel the calf, feel the thigh. But for the knee joint itself, I'm looking to see, is it warm? Is it erythematous? Is there any area of skin breakdown or overlying cellulitis? And then looking for that effusion. If I'm not sure, if we're talking about someone who's got a little extra weight on them, I might grab that ultrasound just to confirm if an effusion is present. And then stability exam, right? This is a big part of what we do and way bigger part of what you do. So this is my approach. ACL and PCL, I'm doing a Lockman test. For varus and valgus stress, I'm going to do that so I can get my MCL and my LCL. And then I'm doing that McMurray side to side, feeling for the click popper, eliciting pain for the meniscus. And that's my exam. So Dr. Parisien, what do you think about that?
So again, I'm going to go back to, you're in the emergency department, and I tell this to patients all the time when they come in and say, well, why didn't they get the MRI there? Why didn't they do this there? And I say, their job is to make sure that your knee is not infected, that you don't have a fracture that's dangerous to walk on, and that you're safe to go out into the world the next few days and with an orthopedic follow-up to maybe get more detailed information as to what might be going on and other management issues. So everything you just hit on there is the things that I would absolutely be looking for, especially in the emergency department. Clearly, you don't want to miss a septic knee. You want to make sure, you want to see if there's an effusion. If there's a large enough an effusion that you can aspirate that knee, I would say, yes, aspirate that knee, set it off for fluid analysis. We can talk more in detail about what we're going to send that off for, but it's really cell count, crystal analysis, as well as gram stain and culture. And then outside of that, you're getting into your exam, and I want to make sure, do they have a patella tendon rupture? Do they have a quad tendon rupture? It's over the age of 45, more likely quad tendon. If it's younger, it's patella tendon. Even though it's atraumatic, I've seen things, or you've heard stories, and things come in and they have these things that you would not expect. So basic stuff. I'm laying them down. Now on the bed, you want to put them in shorts. You want to visualize the knee. Don't do these exams in sweatpants and jeans, things like that. Get them in shorts. See the knee. See what the skin looks like. If there's any skin breakdown over there. I mean, all the basics that we learn that we often forget. And I will still do all of this in my clinic every single day. Why? Because a lot of it's practice too. You're not going to be able to identify a ligamentous lax knee if you haven't examined thousands of knees and you haven't done that exam. So don't just do it when you're looking for it. Do it in every single knee that you examine. Have some sort of a system like you just said. You have your system in place. That's your knee exam. Great. So I'm looking for that. I'm looking at this as a fusion. I'm going to milk that knee, see really if there's like a trace effusion or not, because that's important. Because if people have a focal defect, cartilage defect in a young patient, for example, they might have swelling. If they have some diffuse chondrosis in the compartment, let's say in this 50-year-old, which would be the more common thing, then they could have some swelling associated with that and some overactivity. That is not necessarily a septic knee. Now I'm going to have them range that knee. I'll range it passively. So I'll lay them back completely supine. I'll milk that knee to see if there's any swelling. I might have them push their kneecaps into the table just to look at quad strength, see the symmetry, if they have some significant quad atrophy on one side versus the other side. I'm having to do a straight leg raise, lift the leg up off, no patella tendon, no quad tendon rupture, extensor mechanisms are completely intact. Then I'll see if it's completely straight. Then I'll take the patella and I'll just translate it medial and lateral, see if that causes any pain. Palpate medial and lateral as well. Sometimes people have instability there. I'll also see if they have increased translation or hyperextension, if they have a ligamentous laxity issue. Now, again, this is getting more detailed musculoskeletal examination, but this is, the exam and how I approach it. Then I would, as they're in that extended position, I would then do my Lockman, right? And so you're looking to see if you have any laxity. And really, in a Lockman, you're looking if there's a solid endpoint or not. It's going to be tough to tell if it's less than 5 millimeters or 5 to 6 millimeters, but you want to see if they have that solid endpoint on your Lockman examination. Then I flex them up. I'll palpate the medial and lateral joint lines. Again, asking them, does this hurt here? Does this hurt over here? Is it hurt when I push along the MCL? If you're a pickleballer that hasn't played in a long time, it is very common, especially in middle age, to get a MCL grade 1 strain. And might that patient also have a degenerative meniscus tear right behind that, which is connected to the capsule, which is connected to the deep MCL, so it all blends in the symptoms in that area. Yes, they likely do have a degenerative tear. So some of these things are very common. It would be safe for that patient with a grade 1 MCL strain to go about their day. If you do a ligamentous laxity test with varus and valgus stress, looking at your MCL, LCL, you don't have any laxity there, then you're safe that they don't have a major MCL or LCL rupture. And this is all done with the knee in extension. Now I get it up in flexion 90 degrees, see if they have a sag sign, meaning when you get it up in 90 degrees, this is the femur, this is the tibia. If the tibia sags back, you're concerned that you might have a PCL injury there. Could it be a chronic injury? Fine, but these are all things that you're looking at. And what does that mean? Typically, the tibial plateau, anterior tibial plateau, is going to sit slightly anterior to the femoral condyles when your knees in flexion. And so if the tibial plateau, the anterior tibial plateau drops posterior to the femoral condyles, you'd be concerned for a PCL injury. Okay. Again, it could be a chronic one, but at least you're gathering information now. When I get in the 90, I'm palpating the joint line. Then I'm doing my anterior and posterior drawer testing. And you got to know where the tibia sits in its native position, because you can be fooled if you have a ligamentous injury. You can be fooled to think that you have too much anterior translation when actually you're really starting too posterior because you have a PCL injury. So you're doing the anterior and posterior draw. Then I'll get them up in flexion to see if they flex all the way and see if there's any issues with flexion. Now you've already ruled out septic knee, right? So a patient with a septic joint is not going to allow you to maneuver the knee around, let's flex the knee up like that. If I say as a patient to my residents, if they call and there's a concern for septic knee, and I say, is that patient walking? Are they flexing their knee past 90 degrees on their own comfortably? That knee's not septic. Okay. Low chance of being septic. Let's put it that way. So then I'll get them up in flexion. And like you said, I'll do the McMurrays. And what are you doing with the McMurrays? You're really putting your hand over the anterior part of the knee. You're putting your fingers on the lateral and medial joint lines, and then you're doing McMurrays. You're doing your valgus internal rotation. You're doing your varus external rotation. And you are seeing if you can elicit pain in that patient or if you can get that subluxation of the meniscus. That's not going to happen that often, especially in this patient who has got a BMI of 42, for example. That's going to be challenging to assert. But again, part of your testing armamentarium.
All right. That's great. And it's a lot of information in there, but if you break it down, there's not that much to that. It's good to go back and think about history and think about our tendons, right? So if this guy was just put on steroids and Cipro for a COPD exacerbation, that's going to change our pretest probability for some of these things, and an important history to get. To summarize, we start in the extended position. We see if they can do a straight leg raise, and then you're doing your Lockman.
Answer mechanism is intact. So that rules that out.
Those two parts are out right away.
Yeah.
And you're doing your Lockman extended, and then help us differentiate the extended Lockman test.
Not extended. So you're doing it slightly, the Lockman you're doing is in slight flexion. But my point is, I'm not bending him up, putting him straight, doing this. You can do all that. That's fine. I have him extended. I'm going to do medial lateral translation of that patella. I'm going to palpate the medial lateral patella facets. If it's a young patient that's active, they might have a focal caudal defect there. And then I'm going to slightly flex them as you would a typical Lockman and do the Lockman. But my point is, it's all kind of stepwise, where I'm kind of in this extended knee position, and then I'm going to flex them up. palpate the joint lines, anterior posterior drawer. Oh, I'm also doing varus valgus laxity testing with it extended as well. Then again, flex stop to 90, do that. And then I get them all the way up, flexion. And then I do the McMurray's. And so it just makes for a more efficient examination. And that's, you just kind of just floats through that way. And if it's painful to them, I'll say, is this your pain? Is this why you came into the emergency department today? Right here where I'm pushing. Yes. Okay, great. So then they might have pes around bursitis. Along the bursitis things, they might have prepatellar bursitis. This patient right here, a plumber, a carpenter, active individual like this, who's on their knees, not uncommon to have prepatellar bursitis. So bursitis right over the patella. And so again, it's a matter of examining that, seeing exactly where they have pain. And these things, they'll point exactly in that spot. Or if it's patella tendonitis, they will point exactly on their patella tendon. This is where it hurts. Hurts when I go up and down stairs. Hurts when I'm trying to stand from a seated position.
And they'll notice it that way. Okay. I'm going to help pin down one element for me in clarification. And if they're testing the same thing in different ranges of motion versus different testing, the slightly flexed Lockman and the fully flexed anterior posterior drawer, is there different elements to that, or why are you doing both?
Oh, so the Lockman is going to be the one that is going to be sort of the gold standard, or the pivot shift. And so I didn't get into that. If I'm really concerned for an ACL, I'll do a pivot shift. Okay. So that is where you internally rotate the tibia, place a valgus force. Okay. And you go from flexion to extension, and that's going to reduce the IT band is going to pop, is going to shift that and pivot that and reduce the tibia back underneath the femur. So when you're in the flex position, the tibia is going to be subluxed anteriorly, internally rotate valgus and extension, and it's going to, and then the IT band will reduce that tibia back underneath the femur. And that's a positive pivot shift for an ACL injury. But it's like anything else. Instead of relying on one examination, you have a couple different ones to help you. So really the ACL examination is going to be a Lockman, an anterior drawer, and a pivot shift.
Got it. Awesome. Thank you for that clarification. I think I've been calling my anterior drawer Lockman for probably too long. So thank you.
Anterior drawer, you get them in 90, and then you pull the tibia anterior. The Lockman, they're slightly flexed about 30 to 45 degrees, and then you're pulling, and you're trying to get that. Yeah. So it's a slight flexion. Exactly. And they got to be relaxed. So you got to just talk with them, get them to relax the leg. But the one where you're getting up in 90, you're putting your thumbs on the joint line, on the anterior joint line, A to C, because your thumbs, if you're on the anterior tibial plateau, your thumb should bend slightly over that anterior tibial plateau. Why? Because again, the anterior tibial plateau should be anterior to the femoral condyles at 90 degrees of flexion. So your thumb should bend right over that tibial plateau. If you're putting your fingers like this and you're hitting the femoral condyle first, and that tibial plateau is posterior, concern for chronic PCL injury.
Got it. Awesome. Thank you. All right. So we've examined the knee. We've started an extension. We've done a straight leg raise. We've slightly flexed it. We've done our Lockman. We've brought ourselves up through varying degrees of flexion, doing our anterior posterior drawer, the test that you had mentioned. Now, let's get on to a little bit more of our workup. Our physical exam is a huge part of the atraumatic knee pain workup. And as you mentioned, I really like, and I'm just going to reiterate, focusing on any specific, thumb or finger point specific pain. It's going to point toward our bursitis. It's going to point towards other elements, and recognizing, how that tibial plateau lines up with the femoral condyles is going to give us some information, at least, toward what we're dealing with anatomically. But as we go down,
sorry, Dr. Hine. If you're dealing with a pes around bursitis, you can relieve that patient's pain very quickly with a corticosteroid injection right there in the emergency department. And that's fine. And then they can go through some physical therapy, and you can help them. If you have a large joint effusion, if you get an x-ray, which we'll get into that, if you get an x-ray and you have some significant joint space narrowing, some osteophytosis, and some real severe, degenerative joint changes, you might do the aspiration, send it off, make sure it's not septic, but you may want to hesitate on doing a corticosteroid injection at that moment, because if you send them to your arthroplasty specialist, they're going to have to wait at least 3 months to do total knee arthroplasty surgery. And that's fine, but you just want to educate the patient, about this. And so a lot of the physiatrists that I work with and I train, and they know now, if they're considering doing an injection of corticosteroid, they at least educate the patient, or they'll contact me and say, hey, that we're thinking about doing this, we're considering doing this. Is that okay to go ahead and do that? Just things to know.
Awesome. That's good. I'm going to put a pin in that because we're going to come back to like, once we're in the joint space, what can and what should we do and when should we not do it? So we'll come back to that topic, but all right, workup. So outside of extenuating circumstances, IV drug user or hemodialysis, anything like that, I find general serum labs for atraumatic knee pain to be nearly helpless or worthless, I guess I should say. Even if I think it's gout, as an example, uric acid level in an acute flare doesn't really add a whole lot. Sometimes it's done. People say, oh, it's high. Yeah, but that's there. But is it really meaningful in a lot of ways? Is a question that comes up. So, Dr. Parisien, are there any serum labs that you want in a person with this traumatic knee pain, barring any extenuating circumstances?
No, if you're not concerned for sepsis or any systemic symptoms, and you're really looking for a source of that infection, then no. I would say there's not any, some serum labs that we would get routinely.
Okay, excellent. That one,
because then if you have a young patient, if you have somebody in the woods, where we're getting down the other pathways of like Lyme arthritis, and there's all these other things that you need to be concerned about that can certainly present, but that's really after you roll out all the more common things.
Fair, yeah, that does make sense. All right, so labs, serum labs, anyway. We'll put a pin in other labs for a moment. Not necessarily valuable, barring extenuating circumstances. Imaging. I have to admit, in my atraumatic knee pain patient, especially as they get in advanced years, things like that, I will, on occasion or frequently, get a plain X-ray on these guys. And, if there's a risk for a cancer or something like that, we have our pack per day smoker. Sure, maybe there's a pathological lesion. Maybe I'm justifying it that way, looking for the osteolytics. But I also make myself feel better sometimes saying, well, our orthopods are probably going to want this plain film X-ray, so I'll get it. Is choosing wisely going to slap me in the back of the head? Probably. But how accurate am I in getting these types of studies, or is there any utility to a plain X-ray in an atraumatic knee pain patient?
The physiatrist that will come to my office and train in the office and the residents, I will ask them, how can you tell this? How can you tell that? How can you tell this? Then we'll get the X-ray and we'll go through it. So for all my knee pain patients, I'm getting full length alignment films.
Okay.
Right. So hip to ankle. Why am I doing that? I want to see what their alignment is. I want to see if they have significant varus or valgus. So if they have significant varus, they have significant medial joint space narrowing. These are all helpful for me. If they have medial joint space narrowing, and in that varus and their middle age, they're going to have, obviously they have some arthritic changes in that joint. They're going to have meniscus tear. Is that going to be symptomatic or not? Is it going to be something that is a bucket handle traumatic tear? Are they going to have an underlying root tear? All of these things you're going to find out on MRI later. Also, why am I doing that? I want to take a look at the hip joint. So knee pain can be referred to the hip, and especially in a young patient, you do not want to miss a young, heavier kid who has a SCFE, slipped capital femoral epiphysis, that's coming in. And there's a lot of literature out there that demonstrates that a lot of these patients are going to come in with a primary complaint of knee pain. Mm-hmm. Now, the majority obviously will come in with hip pain, but there is a fair amount that come in with a primary complaint of knee pain. And so in that patient population, I would absolutely get either an AP pelvis, or you just get a full length alignment film. So you can take a look at the hips. Now, if it's any age patient, or let's just say your patient that you have here, severe osteoarthritis of the hip could be radiating down the anterior and anterior medial thigh into the knee, that is presenting as some sort of knee symptoms. They could have osteonecrosis of the femoral head. And so that's also relatively common. It's not overly common, it's relatively common. So they could have osteonecrotic changes of the femoral head and collapse of that femoral head that could be causing referred pain down to the knee. And so I'll get that. I get a standing AP film. I'll get a flexed view that allows me to look at different aspects of the femoral condyles to see if they have an OCD lesion, because many times you're only going to uncover this OCD lesion on the medial femoral condyle in a patient that you get like a Rosenberg view, which is like a 45-degree flexed PA view. And so it's not a straight AP view of standing, which I do get, but then I flex them 45 degrees so you can see along their condyles more, and you can pick up an OCD lesion. Now, in the emergency department, it's not going to change things significantly, but these are all reasons why, plain radiographs can be helpful and why we get them. I'm also getting a merchant view, not a sunrise view. So a sunrise view, they're really flexed and the patella is fully engaged in the trochlea, so you can't see down the joint line. And so I want to be able to see between the patella and the trochlea, so I get a merchant view, which is like a 45 to 60 degree flexed view, so that the patella is at least floating above the trochlea, so you can see between. And you can see, is there some medial lateral translation, any other abnormality that's there. And then I'm also getting a lateral view to see if there's any patella alta or baja or any other abnormalities. Now, in addition to that, yes, there are oncologic or malignant processes that we do find in orthopedics many times, because people will present with some sort of joint or bone-based pain, and we uncover a lot of oncologic issues. And so that is also another reason why it's helpful and beneficial to get an X-ray. In addition to that, like I said, I would say that there's so many patients that come in that say it's atraumatic, that say they don't remember this, they don't remember that, and they have a patella tendon rupture, they have a quad tendon rupture. You won't get an X-ray, but they'll have a fracture potentially somewhere, on that X-ray. And so I think that we're orthopedic surgeons. We analyze plain radiographs. They're extraordinarily useful.
Okay, that's good information. Five things, I don't know. One, alcohol, methamphetamines, opioids are a hell of a drug, and trauma happens without recollection, not uncommonly. So that is an important takeaway, especially for ER docs. Two, the X-ray has utility. And then three, I'm probably not going to be able to get all of the X-rays that you mentioned well and accurately. So there's a pretty high probability in follow-up that you're going to be doing additional films to get the information you may want. Is that accurate to say?
Yeah, well, if we are concerned for ligamentous injury or meniscal injury or focal condyle defect, then we'll be getting an MRI and other follow-up films.
Yeah. Well, and just in terms of the X-rays themselves, you mentioned several X-rays that I don't know if our ER techs will have or do perform. And so I'll get the list. We'll put it in the show notes of the ones that you're typically doing yourself. But I'm also recognizing that the films that are done in the ER may not adequately cover all of the potential X-rays that you may gather as an orthopod.
To rule out what you need to rule out, I think, as far as fracture and to identify if there's any sort of malignant or oncologic process that's happening there, then I would say AP, lateral, and some sort of patellofemoral, which I would say would be a merchant view, should suffice, with consideration of getting an AP pelvis or a full-length alignment film so you can take a look at the hips, especially in a young patient. We don't want to miss a young person with osteonecrosis, subcapital epiphysis, or other sort of, hip-related pathology.
Yeah, fantastic. And that's like board question 101 in emergency medicine in our obese young patient with knee pain. So hopefully we are capturing that and not thinking too much about Skiffy and was a 50-something-year-old painter. But outside of X-rays, advanced imaging, we mentioned briefly MRI. There are a few emergent MRIs out there. Oftentimes we're focusing on thoracic or lumbar, looking for any type of caudal syndrome or spinal epidural abscess. I would say atraumatic knee pain is not one that comes up commonly as an indication for MRI, even including concern for septic arthritis, because we're about to get into joint fluid analysis. So in addition to or subsequent outside of MRI, are there other imaging modalities that you find valuable that are done in the emergency department?
No, plain radiographs are really the most valuable imaging. I mean, obviously the other one that would be common for us would be a CT scan, but that's not going to be as commonly utilized and beneficial. That's really for many times for operative planning purposes that you're getting a CT scan, not just of the knee, but anywhere. And I think with the utilization and your expertise in developing expertise in ultrasound, I think ultrasound can be extraordinarily valuable. And this is something where you, the emergency medicine physicians and our physiatry colleagues are utilized a lot more often than we do. And so that those things can be very helpful. I mean, look, in the shoulder, we published a study showing that ultrasound evaluation of a full thickness rotator cuff tear was just as accurate as an MRI. Now, it got less accurate when you had partial tears or when you're trying to evaluate the subscap, which is a bit deeper, but the ultrasound can be very valuable.
Yeah. Yeah. I'm glad you brought that up because I was going to just put that pitch out there as somebody who loves using bedside ultrasound and you have another knee. So you can always compare and contrast if you're wondering about tendon injuries, ruptures, even bursitis. Ultrasound has some utility from our perspective. So I'm glad that you find it useful as well. All right. Let's talk about the knee effusion, which is kind of where the meat of the conversation and actually the impetus for the podcast and the conversation today came from. So the water on the knee effusion, if a patient lacks risk factors for septic arthritis, they're not engaged in IVDU, they don't undergo dialysis routinely, they're not immunocompromised, brittle diabetic, all the things we know. The joint is not hot, it's not erythematous. Is there value in tapping the joint? And we'll break this down a little bit because there's two ways that could be potentially valuable. So diagnostically, is there any value in fluid assessment, or is that water on the knee almost always osteoarthritis and a simple effusion?
Well, it goes to your pre-test probability, right? So how suspicious are you that this is a septic knee? So if it's this 52-year-old painter worker that comes in, he doesn't have any risk factors. He is actively and you're passively extending and flexing his knee comfortably, or, maybe some minor discomfort when you get out of a deep flexion if he's got some patellofemoral symptoms or even medial joint line symptoms, but relatively comfortable, then in low likelihood that's a septic joint. But it's not hot erythematous, all the other factors. So at that point in time, diagnostically, no, I would not aspirate the joint. Also, everything that we do, even if we think that they're small, minor procedures, all carry some sort of risk. And so is it possible to inoculate a joint that is not septic? Yes, of course, that is possible. So, I'm really, teaching our residents that you're going to aspirate a joint. First of all, if you think that there's enough fluid in there to actually collect enough fluid to be analyzed. And also, do you think, and what is your suspicion that this is truly a septic joint versus someone that has, an effusion secondary to some osteoarthritic changes in overactivity?
Okay. Perfect. I like that. And I use perfectly sterile technique every time. So it's not going to happen to my knees, but it'll happen out there for others. All right. So that's the diagnostic side. How about therapeutically? We have this guy who's got a big old water bag knee, got a known osteoarthritis. We expect it to be a simple effusion. Maybe we can take some of that pressure off and relieve the pain. And then are we and should we be putting a little bit of a cocktail in there, different strokes for different folks. It seems like the ones that I've seen about putting in like 3 mLs of lidocaine, 1%, I guess the 2% is a little more caustic to the cartilage, 0.25% bupivacaine and some triamcinolone is what I've seen out there. So let me ask you that. 1, take the fluid off to be beneficial to the patient. Yes or no? And then 2, are you putting any kind of special sauce in the knee?
So I will aspirate knees or joints in general, but knees, yes, for therapeutic reasons if they're swollen, or in patients that have ACL ruptures, there actually is a fair amount of literature to show that there are really catabolic enzymes that are in that knee that may be deleterious to the articular cartilage, and so it may be helpful actually to aspirate that effusion. So yes, in the office setting. For example, I will do that for therapeutic reasons and purposes for patients. And of course, if you can aspirate 60 to 80 cc's out of a knee, it's going to feel better immediately.
Right.
Now, what do I do after that? Nothing. I do not inject anything back into the knee at that point in time. If I am going to inject, then I typically inject, viscosupplementation or PRP. For the vast majority of patients that I have, because the literature and the data has shown those to be the most beneficial when it comes to full thickness focal chondral defects or some osteoarthritic changes or just some mild to moderate chondrosis. If you're going to do corticosteroid and some sort of an aesthetic, ropivacaine has been shown to be the least chondrotoxic, and so I will only inject ropivacaine into joints. But I'm not a huge proponent of corticosteroid. However, can corticosteroid work? Can it be beneficial when it comes to symptom relief? Of course, yes, it can. There's very good data showing that corticosteroids, especially in an osteoarthritic knee, can certainly be very helpful for symptoms. Just let that patient know that if they're going to be following up with their total knee specialist, they will not be able to do a total knee on you for at least 3 months if we do this injection now. Some of them may say, that's fine. I have no interest in getting a total knee, or I have a bunch of things going on in my life. Please I want the pain relief right now. Fine. At least they're educated on that. Or you will have some that will say, oh, okay, I understand. I'd rather go have that conversation with the total knee arthroplasty specialist. Thank you for aspirating my knee. It feels a lot better because you took out 60 cc's. And I'll go have that conversation with them. And if we determine I'm not going to have a total knee, then maybe we can do an injection at that time in their office with them.
Perfect. Hugely valuable pearl for me, because I didn't know that. I didn't, I'm not injecting most of the knees I do. I'll be honest. I'll take the fluid off and, usually call it a day. If someone is yet to establish with an orthopod, we know our time to see them and go through pre-op and get prep for all that is going to be longer than that time. Sure. I guess that's a consideration. But it's good to know that puts a 3-month blocker on that total knee. So
the vast majority of us are 3 months. And so I just gave a talk, for example, at for American Academy of Orthopedic Surgeons. We had an entire panel and different topics on rotator cuff and I did the orthobiologics and the corticosteroid. The point is, even with rotator cuff, if you give a corticosteroid injection within 1 month prior to a rotator cuff repair, during the rotator cuff repair, or even 1 month following the rotator cuff repair, all those patients have significant increased risk for infection. And so we have similar data across joints. A lot of that is about 6 weeks. Many of us are waiting at least 3 months to do anything within these joints. Even from an arthroscopic standpoint, I'm pretty conservative. I'll still wait that time before I even do an arthroscopic surgery.
Okay. Good to know. Thank you. So 3-month window on that. Shoulders, I'm not injecting those. Knees, good to know about. I'm going to bring you back a little bit because you mentioned something with the bursitis, and this isn't in my clinical practice, but maybe it should be. So if we're recognizing a pes anserine or a prepatellar bursitis, and you can do a cortico injection, tell us your process there. What are you using and how much?
So for the corticosteroid injection of the pes anserine burst, I'm not using much. It's going to be roughly a 2-to-1, just because that space doesn't take much, and it's not going to. Patients can feel uncomfortable in that area because it's not, you're just injecting the bursa, and there's not a lot of soft tissue overlying that area. But with a corticosteroid injection for pes anserine bursitis specifically, it can work very well. I will tell patients you can try icing it, you can try activity modification, non-steroidal anti-inflammatories and Tylenol. The other option, you don't have to do it, is a corticosteroid injection. Now, prepatellar bursitis, you see it less common, and so I'm not really injecting those as commonly. Sometimes compressive wraps and really just staying off the knee. And because the prepatellar bursitis is really one that they're going to be on the knee. They're a plumber or they have some sort of profession, where they're kneeling often if it's possible, because it's really friction based, right? And that's why they're developing this prepatellar bursitis. Sometimes with the olecranon bursitis, not dissimilar. They'll have a lot of friction on their elbow, or they'll even bang their elbow and develop that. So I'm not really injecting those routinely, but with the pes anserine bursitis, I will.
Okay. And what are you using and how much?
Oh, okay. So yeah, you're going to be really just Kenalog and whatever cocktail you have. There's no really, any literature on our end to suggest one over the other.
Okay.
Yeah.
So dealer's choice. Great.
Yeah.
All right. So last bit of this, we're talking about tapping knees. What about the old anticoagulated patient? We're seeing more and more of them. They're going to be on 10A inhibitors, probably more so than warfarin. They got their Eliquis, they got their Xarelto. They got a painful joint. It's got the effusion. It's a little bit warm. If I find that it's a hemarthrosis, we see these joints and we say, this could be a spontaneous hemarthrosis. Might not be. Could be, crystalloid. It could be septic. Whatever in that space, right? We see the knee. It's swollen. They're on 10A inhibitor. Considering honor differential spontaneous hemarthrosis, do you tap these joints to confirm that diagnosis? And on the other side of it, we recognize that it's one of many elements that could be their diagnosis. Are we at risk for inducing a hemarthrosis in somebody that we're trying to rule out a hemarthrosis, if that makes sense?
It makes sense. I mean, if you have a patient that is coming in that has a swollen knee, and again, it goes to your pretest probability. How suspicious are you that this is truly a septic knee versus the hemarthrosis? It can be challenging. I understand that. But if you're concerned that this is a potential septic knee, you don't want to miss that, right? You don't want to miss a septic knee scenario, because obviously if the patient doesn't have significant severe osteoarthritis, then infection is going to degrade that articular cartilage very quickly, and then you could be leading to a systemic sepsis if you are leaving a septic joint left untreated, right? So you certainly don't want to miss that. So in those patients that you're concerned for a large diffusion and that you're concerned for a septic joint, I would say aspirate that joint and then send that fluid for analysis. In the patient that may be on some of these anticoagulants, I would say if they do have an effusion, I would aspirate the joint and make sure that I don't miss a septic knee.
Perfect. Good. I like the simplicity of that answer. And it seems pretty well supported if you look at kind of the literature on the topic. The number of times when people are doing injections or aspirations and inducing hemarthrosis is near zero. So it always comes up, something that we consider. We don't want to do harm when we're trying to do good. But if septic arthritis is on the differential, which usually it is if you're thinking about a warm, painful, swollen knee, then you have to do what you have to do. And if you do good technique and you talk with the patient about risk, sounds like from Dr. Parisien's standpoint anyway, we're good to go.
Yeah, I mean, again, from an orthopedic standpoint, and I think in medicine, it is good to have data. And if you're concerned, you want the data points. You also you don't want to miss some of these things, and a septic joint is certainly one of those.
Yeah, fair enough. All right, so we're going to go forward. We're going to tap our painter's knee. It may be simple osteoarthritic, and we can take the fluid off and help them feel better. We're going to maybe avoid our steroids so that you can see one of our esteemed colleagues and have his knee replaced if need be. But I'm taking this fluid. Let's say it's still on the differential. It's a warm, hot joint. He can't really range appropriately. Septic arthritis is on there. We're going to talk about crystalloid disease as well, crystal arthropathy. I'm going to get that fluid. What am I sending it for? What are the tests that you want? And then after you tell me your answers, tell me what gives you your highest concern, or what are you using as your line in the sand for that septic arthritis? Clearly, we're talking about cell count and the differential.
Clinical examination, right? So you're not aspirating again without your suspicion of clinical exam. And once you've seen a septic knee, then you've seen it and you understand what it looks like. Then if you do the aspiration, you get cell count, right? Crystal analysis, and then gram staining culture. So if you have a cell count over 50,000, that's a septic knee. If you have neutrophils over 90% with a cell count over 50,000, that's a septic knee, especially when it comes with an examination that was concerning, which is, again, the reason why you aspirated. And so that is a patient that has a septic knee. Now, we do the gram staining culture as well. Culture comes back positive. Now you can have specific antibiotic management for that knee. But really, that's what you're looking for in a native joint.
Fantastic. Right down the fairway there. Now, we're from Maine. Well, you are, but I'm a transplant. Are you sending most of those? Are you going to be doing your tick-borne, vector-borne illness serologies on that as well?
I think it's reasonable. I think if you're in those areas that are endemic to these, different sort of, exposures, like Lyme, for example, then yes, I think it's completely reasonable to send for those as well. Because again, especially in a kid, for example, anybody really, but in a kid, you don't want to miss some of these things. And I think it's very reasonable to send off and add those while you have this synovial fluid.
Fantastic. I did that 2 weeks ago. It was the winter, tapped a kid's knee. It looked like numbers were concerning for septic, but we still sent our vector-borne pathologies because it's still an interesting diagnosis that can come up at any time of year, weirdly enough. But all right.
No, without question. And the vast majority of the time, as you know, the vast majority of the time it's going to be negative. Okay. Mm-hmm. And that's fine. It might be negative, but a few times, and if you do it and you work long enough and you aspirate enough, if knees that have effusions, it will pop up, and you're going to feel glad that you diagnosed that patient, because the many weeks and months that patient is now going to go without a diagnosis because they've already had their knee aspirated, it's already been tested, it was clean. They're going to, and they could have some serious problems. And again, anybody, but of course, if you have a young patient who has some underlying Lyme arthritis that has not gone diagnosed, you've really saved that patient and that family a lot by going ahead and adding that to your analysis.
Makes sense. I like it. Yeah, we're not just saying, okay, it's not gout, it's not sepsis, we're going to leave it be. We're still going to keep working our way down the differential. All right, I'm going to do my best to do a summary, unless you have other pointers or pearls right now.
None that I could think of.
All right, you think while I talk. All right. So we have Dr. Parisien here, orthopedic extraordinaire. We're talking about the atraumatic knee pain. We started with our elements of the history, and I actually really liked how we dove into the PQRST of the pain, trying to really localize it, figure out their repetitive trauma, their micro trauma, their work, their profession, anything outside of their normal activities. I added in a little thing about, making sure we're checking out medications that put them at risk. Obviously, their social history is going to come into play in terms of their pre-test probability for septic arthritis, cat arthritis, et cetera. When we got into the physical exam, I like that sort of starting in extension and working our way through. So, right, we're going to do our neurovascular check distally. We can start in full extension and do a straight leg raise to look for any of our tendon ruptures. Clean, easy way to do it. Then we're going to put them in a slight extension and do our Lockman testing. Slight flexion, do our Lockman testing. We can do our varus and valgus stressing, and then we kind of gradually range them further and further. The pearl and tip for me here was to identify that tibial plateau and its location compared to the femoral condyles, epicondyles, to see if there's any malalignment there. And we can do our McMurray and our other testing in that way. Once we go through that physical exam, there is some utility in our x-rays for our orthopod. So don't feel bad if you're getting x-rays and atraumatic knee pain. You can forget choosing wisely. I know it's back pain that they talk about, but you can consider that there as well. For the knee, let's come back to that. We are going to think about our osteolytic lesions. We're going to think about joint space narrowing mediolaterally. There's many x-rays that we are probably not accurately going to get in the emergency department, but we do want to think about hip. We want to think about alignment films, and remind me of the term that is not a sunrise view about the patellar alignment that you added as a consideration. ER.
Yeah, it's a merchant view. And so the merchant view is actually very helpful. The sunrise is almost useless. And so the patella is completely engaged within the trochlea. So even if you add some medial lateral translation or even lateral tilt, you're not going to see that. Also, with the merchant view, you can see down the joint line. And so it just tells you a lot more information. And so even if you're not looking for all of those subtleties, it's a better test to get in general, is the merchant view as opposed to sunrise. It's just like in the shoulder, you want to get a Grassi view, which is a true AP, as opposed to an AP view. Why is that? In the shoulder, so this is the glenoid, this is the humerus and the humeral head. In the AP view, you're going to be like this, or more like this. And so there's an overlap here. A Grassi view is a true AP. It's turning like this, and you're seeing right down the joint line.
So
you can see if there's any posterior translation, anterior translation that might suggest a dislocation. And so the merchant view is similar to a Grassi view in the shoulder, where you're actually getting right down the joint line, giving you a lot more information.
Fantastic. Thank you for adding pros for the shoulder. We're not on that podcast yet, so we'll have you back for that one. But I'll add some imagery. We'll have the merchant view in the show notes for you to consider and show your x-ray text, so that if you're looking to get that view for your orthopods and follow-up, you can get the appropriate films. Very little utility or times where the MRI is going to be useful in the emergency department. We did highlight ultrasound and its utility for bursitis, bursal disease, as well as tendinopathies, tendon ruptures, partial tears. And then we started getting into our workup, our outside of radiographs element. Very little utility to serum blood tests. If we are going to be tapping a knee, which if we have any suspicion for septic arthritis, even if it's hemarthrosis versus, we say, let's go forward with it. Even on someone with anticoagulation, you're data supported. Obviously, you're going to be doing best practices to keep it sterile and try to avoid being very traumatic and inducing a hemarthrosis, but very, very uncommon. And know that you can do this procedure safely without injuring your patient further while you work them up for something more serious. When you get the fluid out, there's therapeutic value in that. Take as much of the fluid out as you can in your osteoarthritic knee effusion to give them some relief. Be conscious and cautious about the agents that you're injecting into it. Ropivacaine seems to be better than the other local anesthetics in sparing the cartilage. Know that if you're going to be putting a steroid in, you're probably putting the person at least 3 months out from their total knee replacement. So consider that, or at least have counsel with them about that before doing that type of injection. And then when you pull your fluids, we're doing our cell count. We're getting our differential of that cell count, gram stain, crystals, and Lyme or other arthropathies, vector-borne illness if you're in the right endemic area. How to do?
Agreed. You don't need us anymore.
Nah, well, I'll still have you interpret my merchant's use for me. But yeah, Dr. Parisien, I thank you so much for being on the podcast. Very educational, entertaining. Love having a familiar face. And I learned a lot. I know our listeners did too. So thanks for coming on.
My pleasure, Dr. Hine. Thanks for all you do.